appreciation more to be a part of this lovely symposium. Lot of concepts have been already introduced, and there is a lot of overlap between my talk and the earlier talks. However, we'll look at a few things in literature and a small study that we have done. The ocular response analyzer has already been introduced earlier. It was available from 2005, and that's when the actual interest in corneal biomechanics increased, because then we had something by which we could in vivo measure the corneal biomechanical properties. And it underwent a few revisions, and currently the third version of the software is available. However, the third version has not yet been FDA approved. So the principle of ORA has already been introduced earlier, so I can skip this slide. When we are talking about the ocular response analyzer, earlier published literature talks only about corneal hysteresis and the corneal resistance factor. However, there were a lot of limitations, as we'll see as we go further. What is important to now understand is that the recent literature concentrates not only on corneal hysteresis and corneal resistance factor, but also on a lot of parameters which are which can be derived from the waveform. Because depending on the shape of the waveform, there are around a total of 41 parameters which can be generated from the ocular response analyzer. So this is a huge list of them, and it is very difficult to understand each and every one of them. But I would just like to mention that most of these, around 40 parameters, can be evaluated, and all of them are analyzed in the upper 75% of the signal peak that you see, and that is for the first 24 parameters, and the rest of them are analyzed from the upper half of the signal peak. And there are parameters which have been studied and reported in literature, include things like the height, which is basically the height of the peak from the base to the maximum peak of the maximum signal peak. Then the width, which is at the bottom, that is at the base of the peak, and things like area under the curve, and aspect ratios, which are ratios between the height and the width, and things like the slope, which is upper slope is at the upper peak, and down slope is when the signal is coming down. So the ORA has a concept of this waveform score, which is demonstrated when you're taking these when you're picking up the readings. The waveform score basically has to be somewhere around 6 or 7, because that's when the ideal waveform can be detected, because it has to take into account movement of the patient, alignment, etc. So it is recommended that when you are studying the patients, you should take at least 3 to 4 readings, and the higher the score, the more reliable the data is supposed to be. However, in literature there are a couple of studies which say that the waveform pattern is, even if the waveform pattern is like how it should be in a normal patient, the waveform score can be low, and hence they recommend that you should not neglect the peaks, the signal peaks which have a low waveform score, and anything above 3.5 can be considered as a normal signal. In the third version of the ORA, something called as the keratoconus match index was introduced. Now what they did is, as I said, there are a lot of parameters which can be evaluated on the ORA. By doing several studies on the normative database and the other groups like keratoconus amongst various universities, they have derived some 7 parameters which are not disclosed, which are very helpful in differentiating normal corneas from ectatic corneas. So these 7 parameters form part of the keratoconus match index, and these are displayed in the third version of the ocular response analyzer. And basically what it does is it compares the KMI to the normals, suspects, and then it classifies keratoconus accordingly: suspects, mild, moderate, and severe. So this is a typical normal waveform where you can see that the peaks are very high, and the peak is very smooth, the amplitude is high, and there are no breaks in the peaks. we just go over some reports in the literature regarding how the values of CH and CRF correlate with age and CCT, etc. This was a study which was published of 207 eyes which were prospectively studied, and they tried to evaluate the relationship between corneal hysteresis and corneal thickness, corneal resistance factor and corneal thickness, and they found that there was a very significant correlation. However, we see that there are some other studies which feel that there is no correlation between CH and CCT. So again, the data in literature is very confusing currently. These people have mentioned that the corneal hysteresis increased with increasing corneal thickness, but the correlation was moderate. And they feel that these are the parameters which you should consider during intraocular pressure assessment, as has been highlighted by the previous speakers. CH and CRF definitely reduce with increasing age. Also, CH and CRF have been studied in relation to refractive errors. No correlation between CH, CRF and astigmatism has been found. However, some correlation between the CRF and myopes has been reported, but we really don't know how much of clinical use it is currently. So basically, apart from research purposes, we can use the ORA in preoperative screening in refractive surgery patients and evaluating ectatic disorders. We all understand now that low CH and CRF are associated with ectatic diseases like keratoconus, form first keratoconus and pellucid marginal degeneration. However, we really don't need the ORA to differentiate or diagnose a keratoconus case. What we need the ORA to help us is to know whether it's a form first keratoconus or it's an early suspect, and that's what we need to differentiate from a normal patient. However, the earlier studies on CH and CRF had absolutely variable reports. Keratoconus could be differentiated on the basis of CH and CRF. However, form first keratoconus, according to some studies, could not be differentiated from normal patients. So this is the waveform signal in our form first keratoconus patients, where you see that the amplitude is slightly lower and the peaks are not very smooth, and the CH and the CRF is lower than normal. In a keratoconus case, you see that the amplitude is very low and there are breaks in the peak also. So there are a lot of studies which have been done to correlate the severity of the keratoconus and correlated to CH and CRF, and they've also tried to correlate it to the vision and the abrasions. So they have concluded that the CRF is the most important parameter, and it does correlate with spherical abrasions in several keratoconus. Now, because of the problems associated with CH and CRF not allowing us to differentiate with early or suspect cases from normal cases, there was a lot of interest in the parameters other than CH and CRF. So there are a lot of studies who have reported they have used almost 40 parameters in evaluating different keratoconus groups. These can be the suspects or form first keratoconus or keratoconus patients, and the problem in literature is that there is no uniformity in the way the keratoconus has been classified. People have used different ways of classifying, and because the database is different, we yet do not have an answer as to which of those parameters out of the 40 are the best, which will help us to identify early keratoconus. Like this one study had published like that CRF and area under the peak 2 was very significant in differentiating keratoconus from normal, and 14 of these parameters related with the severity of the keratoconus. So to answer this question, we did a small study when I was doing my fellowship at Jules Time. We studied normal patients, then patients with keratoconus and patients with form first keratoconus. These were divided into two groups. Group A were the patients who had a keratoconus severity score of 0 or 1, and these were the fellow eyes of the patients who had keratoconus. Whereas FFKC and Group B had one eye of the patient who had form first keratoconus. And as you see that the age is almost similar in all the groups. The corneal hysteresis in the normal group was around 11. You see the range of hysteresis in the normal population is between 7.9 and 15.7. The CH and the CRF were lower in all the other groups as compared to the normals, as we expect, but I would like you to draw your attention to the range. As you see here, even a patient with keratoconus which was diagnosed clinically, had a value of 11.4, which is also within this range. So this itself tells us that we need to understand a lot more about these waveforms, and only CH and CRF are not important in differentiating. We plotted all the 41 parameters by performing multiple variable regression analysis, and we plotted the ROC curve. And what we understood that in keratoconus, differentiating between keratoconus and normals was not a very difficult thing. A lot of the parameters were significantly different and lower in keratoconus patients. However, the CRF, the width 2 and the A index. A index is the smoothness of the curve. Like if there are a lot of breaks, then you'll get a lower value. Those were the most important parameters to differentiate between normals and keratoconus. And the sensitivity of these indices was 97.3 and specificity was 93.9. However, when we tried to do the same thing with form plus keratoconus versus normals, we realized that only 14 of these parameters were significantly different. And the most important parameters were CRF and W2. And this had a low sensitivity but a higher specificity. So after this study, CRF was routinely included in the refractive screening of the patients who like pre-LASIK, and if at all there was a lower CRF value, then the patient was advised against surgery and the evaluation was repeated. Post-LASIK, this is the ORA in a normal patient, and post-LASIK you see that again the amplitude is very low and the signal is not smooth and the CH is very low. And there are a lot of studies which have compared these values with keratoconus, and they have concluded that post-LASIK eyes also have very low values, very similar to patients with ectatic disorders. Also, there has been a report on the difference in the CH and the CRF after using the SMILE procedure, because it is said that probably does not weaken the cornea as much. And basically the corneal, the decrease in the CH and CRF may not be only because of the cornea becoming thin in LASIK, but because of the creation of the flap. So in SMILE, CH and CRF did reduce, but there was no difference between SMILE and femto-LASIK according to one of the studies. As far as Intax is concerned, there was a temporary decrease in the CRF which was observed. However, in the later post-operative period, no difference was observed. In fuchs endothelial dystrophy also, we note very low CH and CRH values. Other clinical conditions that have been reported are like there's been no change noted in pregnancy, and in patients with PK, you do have a lower CH and CRF value as compared to DALC, but this is only into the initial post-operative period. There is no difference at one year. Cross-linking, we can use this tool to evaluate the effect of our cross-linking on the patients, and this was a patient who pre-cross-linking was classified as a moderate keratoconus, and 6 months after cross-linking you see that the value has changed and now the patient comes under the mild category. So I would like to conclude by saying that evaluation of the corneal biomechanics is still evolving. It does have a role in understanding disease pathology. It may influence your treatment to a certain extent, because the more you understand different parameters, the more you can use them in your clinical practice. However, the answer to which parameters should you look for is still debatable. It may in future help to establish patient-specific customized treatments. And it being a dynamic form of assessment does complement the static form of assessment like topography. But currently, at least with the ORA, there is a variability in the data. There is a lot of overlap between what you get in normal patients and patients with ectatic disorders in early stages. There is a lot of problem with repeatability, especially if it's an ectatic disorder patient. So I think the ORA needs to be understood much more, and probably newer devices like the Corvus may answer a lot of unanswered questions. Thank you.